A 6-year-old child has come in to see you with their parents. They're concerned about the child's behaviour, and they tell you that for the last few years at nursery and now at school, teachers and care assistants have said to you that they're concerned this child might have ADHD. They seem to struggle with attention spans, they seem to find it difficult concentrating, and they can be quite restless in class. But actually, when you look at the child in front of you, they don't seem to be displaying any obvious symptoms. What they are doing is they're breathing through their mouth and their speech is slightly nasal. Could this be something other than ADHD? Well, actually 25% of children who present with features like ADHD will have obstructive sleep apnea as the underlying cause. This is a condition that we rarely associate with children but does affect 1 to 2% every year. There are two groups of obstructive sleep apnea in children. The uncomplicated ones, which are usually caused by increased size of the adenoids and the tonsils in otherwise healthy children, and complicated cases, which are more likely to be due to structural deformities, other conditions such as Down syndrome, or the leading cause now, which is obesity in childhood. You're likely to get a history from the parents that may include those behavioural changes, but it will definitely include snoring at night time, and they may well have been doing that for their whole lives. You may find that they describe an abnormal sleeping posture where the child will sleep with their head tipped back, trying to clear the airways, and they may also have noticed some of those typical snoring and noisy breathing sounds during the day, which is called stertor. If you have a child like this who is exhibiting those symptoms despite not having an upper respiratory tract infection, then think about obstructive sleep apnea. Sometimes they can have apneic episodes, although often they would present more acutely than this. And unlike a lot of paediatric problems, where we would do watchful waiting and see what happened, actually the advice when the BJGP wrote this up was that we should be referring these children sooner. If it's an uncomplicated case, then there's really good evidence for adenotonsillectomy, and children do very well following on from this. If it's a complicated case, they may need to be referred elsewhere, but actually there's also some evidence that even if the cause is obesity and we appropriately support that child through weight loss, they may still benefit from surgery. So next time you see a child who has behavioural concerns, just think about examining their ear, nose and throat and considering obstructive sleep apnea as a differential diagnosis. This is one of many topics that we cover on the MB Medical courses. We hope to see you on one soon.